bringing together voices in child and youth healthcare. This is CAPHC Presents.
CAPHC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAPHC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAPHC Tweets and using the hashtag CAPHC Presents. All of our webinars are recorded and can be found on the CAPHC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAPHC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive. Hello, everyone, and welcome to today's episode of CAPHC Presents. I'm Doug Maynard, the Associate Director at CAPHC, the Canadian Association of Paediatric Health Centres. And today we're going to be talking about data collection in the ambulatory and community-based rehabilitation services sector. And today's going to be a great presentation as we get to talk about a very interesting topic, which is the importance of data to the child and youth rehab services sector. But it's also a great opportunity to showcase some of CAPHC's work that is being led by individuals from across the CAPHC community that has resulted after many years in a program and partnership with the Canadian Institute for Health Information that we like to call PRRS, or the Paediatric Rehabilitation Reporting System. And before we introduce our panel, I've had the pleasure of being part of this work since about 2008, and it started even before that with a small group of individuals from the rehab centers that were CAPHC's members under the network that they formed within CAPHC called the Canadian Network of Child and Youth Rehab. And when they started to develop a national minimum data set and really trying to plug along without much in the way of resources or anything else, just with a little bit of passion. But it was in 2010 when we had the opportunity to connect with Alexandre Bilodeau, the Olympic gold medalist, who came to CAPHC and wanted to donate some of his winnings to support something related to cerebral palsy. And we really saw that as an opportunity at that time to perhaps start to put some money behind this national minimum data set project and really see what we could do with it. And then that started a long journey since 2010 with Alexandre helping connect us with many other partners and corporations that he was connected with, both within the Montreal and Quebec community and across Canada. He introduced us to Le Groupe Perron, which is part of the Bank of Montreal organization, CIBC and the Miracle Day Foundation, the Power Corporation of Canada, and that's really what allowed us, provided us with the funds to move this project along that has now become PRRS, or the Pediatric Rehabilitation Reporting System. So without any further ado, I'd like to introduce our panel, which includes some of the individuals that have carried this work over the years. Many have, it's been such a long journey, many have moved on, some have even retired, it's been that long. But it's great to have a few individuals here who have been part of this throughout, at least for a lot of the work that has happened. So we're going to be hearing, we have with us today Dorothy Harvey. Dorothy is currently the co-chair of the PRRS Steering Committee and a member of the CINSER, that's the Canadian Network of Child and Youth Rehab, their leadership council. Dorothy is a physiotherapist and a manager of rehabilitation services at the Niagara Children's Centre in St. Catharines, Ontario. And she also represents OCRS, the Ontario Association of Children's Rehabilitation Services, at the PRRS table. And joining Dorothy is Ms. Adrienne Zerum. Adrienne is a family leader at the Holland Bloorview Rehabilitation Hospital in Toronto. She's been a member of the steering committee of PRRS for just over 2 years, and in her role as family leader, she brings client and family perspectives to the table. Adrienne's also a mother of 2 young girls, the youngest of which was diagnosed with autism at the age of 2. And she currently works on a number of projects at Holland Bloorview, including serving as the co-chair of the Family Leader Accreditation Group as they prepare for their 2017 hospital accreditation. And last but not least, CM Javid, one of our close colleagues here at CAPHC, is the Senior Health Information Analyst and Program Manager for the PRRS reporting system at CAPHC and with the Canadian Paediatric Decision Support Network. So a great panel today. Don't hesitate to type any questions that you might have as you think of them, and we'll be certainly happy to answer any questions that you have. And it's my pleasure to hand the virtual podium over to Dorothy Harvey.
We see this both as an opportunity to talk about some of the great work that we've done, but also to engage some of our partners to become part of our journey with us. So I'm going to be setting the context for talking a little bit about the motivation behind PRRS. I'll be handing over the reins to CM to talk about some specifics related to it. And then I think most importantly, we're going to get a really great family perspective from Adrian. This certainly has been a journey with parents and families, because the whole journey of pediatric rehab is often one that we're traversing together. So how fitting that we have a very strong presence of families in this project, and we have somebody as articulate as Adrian to talk about it from her perspective. So if we start to think about pediatric rehab, really we look at a system that really isn't necessarily a cohesive system. We have services that are structured under various provincial ministries. Sometimes within ministries there's even different streams or silos of them. There's definitely inter and intra-provincial variability and availability of pediatric rehab. We also have service delivery through various funding, and this is certainly something families have experienced, where their rehab services may be provided by a mix of public and private. They may have various accountability arrangements. Certain provinces, the parents are being paid to provide their service and solicit their service. In other areas, they're getting it directly from service providers who are funded through the publicly available system. We also have situations where we have families also looking at outside of what we would consider traditional pediatric rehab and starting to look at alternative care or other opportunities for their children. One of the areas that we've quickly identified is that we know that within the healthcare system, and certainly within the acute care system, there's a much probably easier way of capturing data, and there's definitely been a focus on the metrics in most health systems, even including in pediatrics. But when we think about pediatric rehabilitation and the community-based services, we really haven't advanced our data collection, and certainly not done so in a comprehensive, cohesive way. It is a bit challenging because of the fact that we do have this mix of providers and accountability arrangements. And certainly one of the areas that we've also identified is that need, if we're going to really think about improving the system, how do we look at some standardization to identify and improve access to service and ensure sustainability of our publicly funded system? So where did the whole concept of PRRS come from? Doug provided some perspective on the fact that a group of very forward-thinking leaders of pediatric rehab facilities across the country came together back in 2004, and that was really to look at trying to develop a network of community-based and hospital-based providers to think about how can we start to look at commonalities across provincial boundaries, how can we look at improving the state of our pediatric health system and our pediatric rehab system. That group together spent the first part of their work thinking about how do we get people together, how do we develop a strong network, what's the purpose of a network for child and youth rehabilitation, how is that different than other types of networks or similar to it in different ways, who needs to be engaged in it, what's our structure, and you know, we have to be certainly thankful to CAPHC because we are a little bit of an oddball in the CAPHC world, but they've supported us over the last number of years in pulling this kind of group together and looking at what are some of those areas. We also looked at what was our work plan in developing specific and attainable goals and objectives. one of the very early priorities was the concept of developing a national report card for pediatric rehab. How could we possibly know how to improve the system if we didn't really understand what was happening within the system at that point in time? It was challenging because there really wasn't information in the literature about how do you go about this. There wasn't consensus on standards of care or resources or definitions and process. And so one of the first early workings of the CINSR network was to establish an outcomes and benchmarking committee to really investigate and recommend a conceptual framework and methodology for how we might do a standardized data collection system across Canada. So it gets to why is it important. So our kids deserve the very best. We are nationally, there was no concerted or organized way of tracking the rates of disability in children or their outcomes. Ideally, there was an identification of best-in-class centers, which will allow for sharing of best care practices for safe and affectionate care. There was comparative data that we needed to think about. It allows us to do resource utilization to assure sustainability and accountability of service provider organizations. It will allow us as providers to reliably predict future trends. I mean, many of us have certainly seen the change in demographics of the types of kids we're serving, the complexity of them. So again, without having this ability to have a repository for where we can look at some of those things, how would we know what was coming down the pipe for us as rehab providers? But also provided us a way of creating a yardstick for service or outcomes improvement. And it would allow us, most importantly, to effectively plan our healthcare services to meet those needs. Most importantly, it really was a perception that we can and we must do better to improve services and health outcomes for both our children and their families. To give you a bit of a perspective on what the lay of the land is, a mapping exercise was also done by CINSR, and this gives you a concept of the different pediatric rehab facilities across Canada, and a little bit of kind of already some concepts around kind of when we look at where services are located. Some of these are tertiary-based services. Some of them are more community-based services. So it also provides you with a bit of the concept of the challenge of bringing this group of various providers at various levels, funded under various ministries, together to think about how would we collect data at a national level. So how do we see us moving forward, and what's the goal and purpose of the PRRS project? And Doug alluded to the fact that this has been an ongoing process that CM will talk a little bit more about. And it started off as thinking about a national minimum data set. We dropped the minimum after year one and then moved it towards more looking at what do we need to put in place in order, and what would the purpose be to have a pediatric rehab reporting system. So one is to collect meaningful data from rehab treatment centers across Canada for collation, knowledge translation, and to support service improvement. It's to provide standardized data about a service sector and associated client groups that have traditionally been underrepresented in data collection, reporting, and knowledge translation initiatives. And it's also look at a way of collecting and linking data sets across the continuum of care. The beauty of this work is that we see this as a bridge between some of the metrics that are being collected within more tertiary acute care facilities, and also the opportunity to do some analysis as we look at the adult rehab system as well, and where our children are going to be going into across their lifespan. What will the journey be? In our initial discussions, we certainly see this being as something that would be comprehensive for all children and families and all different types of targeted services looking at particular conditions for children. The initial rollout was to really look at being able to specify some diagnostic groupings that were common across most of our centers. So while the long-term goal is that we would be looking at outpatient ambulatory services targeting children, and that would include children with developmental or behavioral conditions, neuromotor and neurological conditions, the initial rollout was to target specifically the populations of autism spectrum disorder and cerebral palsy. we wanted to take a longitudinal approach. So again, unlike the metrics that are often being collected within the health system, where are more episodic or it's care-based or it's length of stay-based, we really wanted to think about this over the lifespan of a child and a family. So thinking about what are the things that we need to be collecting both at entry into service in order to look at those parameters and to look at where do we have specific issues related to things like weight or access. We then also wanted to think about kind of the outcomes of our system. So looking already at an outcomes-focused approach. So looking at as well the fact that our outcomes for most of us in pediatric rehab are now very strongly linked to the International Classification of Functioning Child and Youth and the whole notion of participation and activity outcomes as opposed to more traditional outcomes that were maybe more related to activity and more functional body structure outcomes. So we looked at when are some key points in time that it would be important to collect this. And transitions is always something that our families are identifying as being areas that are where we're starting to look at potentially changes to the service system. Children are entering to school, children are changing sometimes their service delivery model. So really trying to focus on the ability to analyze at those key transition points. So looking at that transition into elementary school, early learning programs. Then the next transition often is coming into just going into that high school, and then also looking at some transitions as we're planning for children to enter the adult system. That is where we started from, and then I'm going to pass it over to CM now to talk a little bit about how we decided what data and then where we went for there.
Thank you, Dorothy. I just want to just turn it over now to shift gears to a very exciting phase now that we've addressed the motivation, the need, and the gap. And thanks so much, Dorothy, for setting the stage and clarifying those areas. But now we're at a point where we're going to ask questions around answering what data is required to answer those particular questions that Dorothy just alluded to meet and serve the needs of those areas of in that particular age group that was just highlighted a few minutes ago. I'm going to turn it over to the goal. The goal now being to deliver better data, better decisions for better and healthier Canadians. We focused on highlighting the following 4 core areas when we took a look at the pediatric rehab reporting data elements. We took a look around clients and clinicians having evidence for the right treatment in the right place at the right time. Healthcare organizations having evidence to inform quality improvement and resource utilization. Inpatient and community partners have information for continuity of care across settings. And system-level planners having information, having evidence to raise awareness and improve care within Canada. So how did we approach addressing these 4 key areas? Apologies. There was about a large group that participated in the creation of the data set. A group of subject matter experts, clinicians, the Canadian Institute for Health Information, and CAPHC's Canadian Paediatric Decision Support Network, as well as families from across the country, including Adrienne Zerum, a lead who participated in the development of a few of our tools that she'll speak to momentarily. We also addressed across the country, collaborated for several months how to outline the information that is needed to provide an initial list of data elements that organizations already collected or could be at least reasonably collected. CIHI and CAPHC facilitated 2 small pilot groups. Those pilot groups were held in 2012 and in 2013. And that was really an opportunity to create a data set, and we'll allude to what that data set looks like in a few minutes. A data set that was reasonable to be collected, a data set that could be captured nationally. It was with the experts from across the country that participated in several months to help us create this first initial platform. It is also important to note that the International Classification of Functioning, Disability, and Health Framework was used to ensure that information collected was anchored in quality dimension and effectiveness around accessibility, effectiveness, efficiency, client and family centered care. This was really important initially when we started drafting the first data elements, that we took a close look at what this framework spoke to. The ICF framework also addressed effectiveness of dimension around impairment, activity, participation, environment, and personal factors. You'll see this in the two tools that were introduced as participating in the data collection process. It was also important to demonstrate proof of concept. So can the national data set at that time when the two pilot studies were conducted, can the data set truly collect information from across the country? And in order to take a closer look at that, we took a look at feasibility in scaling up. A retrospective study was conducted along with a prospective study. At the end of 2013, a national report was released that demonstrated that the project was feasible. Now, the question was, how do we move to standardization? How do we provide a data set that can actually be standardized from across the country? How do we define these data elements? What next steps needed to take place? It was at that point that the national data set transitioned under the CAPHC's Canadian Paediatric Decision Support Network in partnership with the Canadian Institute for Health Information, along with a group of content experts. We're involved on a monthly basis in strengthening and standardizing the Pediatric Rehab Reporting System data set. And that was to ensure clear and common definitions were specified. I'd like to recognize the clinicians and content experts that it was about a year and a half of work that really sat on these calls, sometimes once a month, sometimes more than once a month, to help us standardize and define these data elements. We identified what was mandatory versus what was optional, ensured standard codes and formats were adopted, so things that fell under ICD-10 codes. We created population-specific pick lists to facilitate data collection, created a data specifications document for clients and vendors. That data specifications document proved its success as a result of the implementation phase that we are now in 2017. We acquired necessary intellectual property rights to use and report desired clinical assessment tools. I'd like to highlight the 62 data elements that fall under 6 domains. Under client identifiers and sociodemographic data, so for example, healthcare number, gender, birth date, administrative data around referral date, clinical contact date, health characteristics, and these are just to name a few: classification of severity, function, activity, and participation, intervention resource characteristics to identify frequencies and locations of services received. I also want to highlight that in order to start the development of the National Pediatric Rehab Reporting System, it was important that the group of content experts focused on two populations, and that was autism and CP. And really that would lay the foundation of what the future of the pediatric rehab reporting system would look like as we move forward in collecting other diagnoses in the future. I'd also want to highlight the standardized point of care, that it was important to in the data set to look at how the data elements would affect individual and provide information to individuals, to organizations, and system-level planners. How would system-level planners be able to monitor performance through the data set, demonstrate accountability, align resources and funding? The questions were asked around evaluating services and programs, comparing with peers, allocating resources, Are there differences in the resources that are being used in sites that are located in the West versus the East? These questions came up frequently. Assessing individual health status, making clinical decisions. Are we evaluating the care of the individual? And that's the key areas where our parents played a role in developing those data elements. I'm going to turn it over to now to talk a little bit about the national implementation story. Now that we've defined the data set, and you know that the general 62 data elements are structured under the characteristics of function measures, healthcare number, health characteristics, administrative data elements, it's important to understand how this process moved forward. As Dorothy alluded to earlier in the webinar, in 2014, the CINSR transitioned its national data set under CPDSN. And what that really meant was, how can we use the expertise of national benchmarking within pediatrics around, and CPDSN plays a key role in benchmarking around ambulatory, financial, surgical wait times, KPIs, but now we had the opportunity to bring those expertise to the pediatric rehab reporting system. Establishing a relationship with CIHI and its many collaborative projects was an opportunity for PRRS to use those particular tools and to leverage off of the existing technology and platform that CIHI was releasing, and I'll explain how we took that opportunity in the next slide. CAPHC's commitment to fund the database development, as well as the commitment of CIHI to take on PRRS to build the repository, was an opportunity to move the PRRS initiative to now be held under CPDSN. During the last month, after the requirement specifications was released, CAPHC and CIHI played a huge role in the implementation process from the ground level at the local sites, providing those training and support sessions not only for those that would be collecting the data set, but also for the vendors, for the IT teams at each facility, for those folks that are clinicians and what their role would be in data collection. The process maps varied from each site from coast to coast, and it's important to highlight that specification because it's really unique as the project varies from site to site. What's so unique about it is that each process map also differs, but there's also some common themes. And now I'd like to just speak a little bit about the Nacrs Clinic Lite. This was an opportunity in 2015. The Canadian Institute for Health Information released a Clinic Lite option. And this particular option is CIHI's National Ambulatory Care Reporting System. It's a Clinic Lite submission option which provides a low-cost, rapid implementation methodology to collect patient-level information from outpatient clinics. The new submission option is generic enough to support multiple clinic types, both hospital and community-based, and provides the capacity for customized data collection of interest. It was in 2015 that Clinic Lite was released, and at that point, the Pediatric Rehab Reporting System was able to use this particular repository platform for the PRRS data set to be held in. As it also validated credibility, privacy impact assessments took place, data quality checks are in place, validated integrity, and a standardized process for all sites participating from coast to coast to standardize their data elements. So what have we done since 2015 when the PRRS data set went live? We introduced technical meetings, I would say starting from September 2015 till ending of 2016. and those were held on a monthly basis. We launched the web entry tool, which is a customized PRRS tool. So those sites that did not have vendors or were very small sites, they used this customized web entry tool, which is now available. In January 2016, we launched a phase 1 of the implementation across all 6 sites. In November to December 2016, we completed a data submission testing process. That was just a few months ago, and some of our champions will be highlighted. In January 2017, we're onboarding new PRRS sites, as well as having for the first time ever live PRRS data. So it is a very exciting phase for us. I just want to highlight our champions in year 1. Kitimat Child and Development Center in British Columbia, the Glenrose Rehabilitation Hospital in Alberta, Alvin Buckwild Child Development Program in Saskatchewan, the Holland Bloorview Kids Rehabilitation Center in Ontario, IWK Health Center in Nova Scotia, and Specialized Services for Children and Youth in Manitoba, previously known as the Rehabilitation Center for Children, RCC. These were our 6 sites that proved that the implementation process was one that was successful, but not as easy as we thought it would be when we first started. It's important to highlight some of these lessons learned in year 1. The value of the infrastructure was key. Being able to work with the Canadian Institute for Health Information, CIHI, and their clinic environment tool, the Nacrs Clinic Lite tool, was a wonderful opportunity to leverage this technology and to build a repository where sites from across the country would be able to use. To also understand the vendor needs, so that technical specifications requirement document I referred to earlier played a key role in delivering the specifications from not only one vendor, but from various vendors. The value of peer-to-peer collaboration across the country, so how one site is implementing the reporting system and using similar models based on the size of the organization and approaching a peer-to-peer collaboration and implementation was truly a success. And we will continue to use this particular model as we move forward. The communication within each site, so clinicians, a technical team, administrators, ensuring that the information that was delivered not only to the site lead was also delivered to the clinicians that are participating in the project. The technical team also understood the requirement specifications needed in order to build an interface if that was the approach being used. The administrators who may collect the first set of data elements understood the specifications required. It was important to speak to the various different groups that were participating in order to ensure that standardization of the data elements were met. Flexibility was also something that we learned in the last year, that although some sites may be ready a little bit earlier or maybe be able to implement the first set of data elements, we also ensured that the phasing of adding new tools like the PEDICAT and the PEMCY would be something that would be a flexible approach depending on the readiness of the facility. Data collection in phases was also something that was applied and will continue to be an approach for PRRS. The family role and the leadership that folks like Adrian Zarin played in delivering important information to families and in delivering the tools like the PEDICAT and the PEMCY, providing that type of information and perspective from the family was one that played a key role as well in implementation. And leveraging analytics, tools, and resources, ensuring that we leverage the analytics provided within CAPHC's CPDSN Decision Support Network, as well as CIHI. Analytics that have been provided for years within the CAPHC office, and to advance those and reciprocate those to the PRRS project was imperative. Alongside our 6 champions, we are looking to onboard in year 2 Sunny Hill Health Center located in BC, the BC Association for Child Development Intervention in BC, and Kitimat Child Development Centre is a member of the BC Association, Vancouver Island Health Authority, the Alberta Children's Hospital in Alberta, Regina Capel with Scanner Rehabilitation Centre in Saskatchewan, Ontario Association of Children's Rehabilitation Services, Oakers in Ontario, and Eastern Health located in Newfoundland. I will now turn it over to Adrienne Zarum to speak to her story through and her discovery and value and commitment throughout the PRRS journey. So over to you, Adrienne.
Thanks so much, CM. My name is Adrienne. I am a family leader with Helen Bullerview and a partner in the PRRS initiative. So my connection to PRRS is a personal one. The face that you'll see before you is the face of my 5-year-old daughter, Amira. Amira was diagnosed with autism at the age of 2. The happy and carefree expression that you see here is one that has slowly and progressively blossomed over the last 3 years, but it's not one that we saw very often when she was a young toddler. At 2, she seemed trapped in her own little body. She experienced severe difficulty communicating and had frequent self-injurious meltdowns, and suffered from many complex medical issues that clinicians couldn't seem to pin down. The fact of the matter was that life was very difficult back then, and when we received her diagnosis, there was definitely a period of mourning. Mourning the loss of what I thought would be, what I expected her future to look like, what I assumed our family's future would look like. And while I mourned for some time, the next overriding feeling that came over me was the feeling of being overwhelmed. We were overwhelmed with so much information, so much jargon, so much planning. It was information overload. We had just assumed that because autism wasn't a rare condition, that there would be multiple specialists to consult with. We assumed that we would soon come upon a clear and defined roadmap for treatment that would indicate what kind of intervention she needed and detail when and where she was going to receive it. We quickly realized that the world of chronic pediatric rehabilitation is very different than that of pediatric acute care, and we soon realized that there would be no roadmap and that we would need to navigate the system on our own. It truly felt like we were on a roller coaster emotionally, physically, and mentally, all the while trying our best to navigate, support, and retain some normalcy for Amira and her neurotypical older sister. As we got our footing, figured out what some of the acronyms meant, and got on a number of waiting lists, the feeling of frustration set in. Why doesn't the system have a roadmap for us? Clearly, we are not the first family to receive this diagnosis or ask these questions. What do you mean you don't have any information on wait times, outcomes, geographical differences, therapy models? Really? But out of that frustration grew the realization that our only option was to forge ahead. Even though it meant that I felt pretty uncertain most of the time, in time I found my strength. We found an amazing team of professionals that helped nurture Amira's growth and development, and over the years, she's made amazing progress. Nowadays, that child that I worried might never be able to use language to communicate chats my ear off on a regular basis, and on a good day, stares into my eyes when she says, "I love you, Mommy." Amira and I have fought this fight together, and I feel incredibly lucky to be able to say that I think we're winning. I found my strength as a mom and a champion of a kiddo with special needs, and in trying to make this road a little easier for families to come. So when we think of the idea of making this road easier for families to come, we of course have to ask ourselves, why PRRS? Presently, the system doesn't have a centralized way of collecting information on childhood disability that can be shared not only within an organization, but across organizations, provinces, regions, etc. Necessary information that can help influence policy, allocate resources, and direct planning and funding. As a parent and user of the system, I'm fully aware that resources are limited, often at the mercy of lobby groups, and too often, families are left feeling like their children don't have timely access to appropriate and necessary interventions. There are families that move cities, regions, and even provinces just to get what they hope will be better care. And often these moves are made without data, without concrete information, and simply based on the hope or word from some internal network that things are better over there. What we need in the collective we is a system of accountability that can help us make appropriate decisions, allow for the repurposing of resources to address bottlenecks in service, and ensure equitable flow of resources. And PRRS can help us do this. How? By collecting standardized information that's not only clinically relevant, but also relevant to families, such as wait times, classification codes, and outcome measures. This will help us partner together to influence system change. We can understand the regional differences, provincial differences, and figure out a collective solution. But to make this happen, we need organizations and families to commit to this and to broaden the collection of information in partnership with CIHI to all childhood conditions. While my story is about autism, there are many other parents that desperately need data about their own child's condition, and the system needs help to better understand how we move forward in an effort to better help outcomes. So what has been my role? Firstly, it was learning the meanings of another boatload of acronyms and then trying to get my brain around what the heck PRRS was in the first place. I won't lie, it took a while, and I needed to figure out how to become a partner in the process in a way that would allow me to be helpful, informative, and an equal at the table. It took the entire group's understanding that we, administrators, clinicians, and families, all have strengths that can contribute to a better experience for all involved, but most importantly for our children. In this respect, I truly had it easy. The team at Holland Blue Review and the entire PRRS steering committee has and continues to walk the walk when it comes to genuine, meaningful, and authentically integrated partnerships. I want to share a real-life example of how this works. When the PRRS team's discussion turned to the actual gathering information from patients and families, as a family leader, I wanted to know exactly what we were asking of families, how were we asking for it, and during what point in a patient's healthcare journey would we be asking. We discussed being conscientious of timings of our asks and came up with strategies related to doing our best to not overwhelm families with a request of additional information at key stressful moments, like a delivery of a diagnosis or other impactful information. We discussed creating spaces within our institutions where kids could be attended to while parents filled out paperwork uninterrupted. We talked about using technology to make the process of gathering information more efficient and user-friendly, and I was able to advise the group and give feedback about one of our outcome measures, the PEMCY, that we now have a web-based format for. When it came to the discussion of how we were going to share information with families about PRRS, I proposed the idea of creating a family-friendly summary sheet that could be distributed to families who were volunteering their data. The team embraced the idea, and in short order, the co-chair of our steering committee had put pen to paper and created an initial draft. When I received the initial draft, I have to be honest, my heart sank. I couldn't figure out how I was going to communicate to our leader that this wasn't quite what I was expecting. And up on the screen, you'll see what was page 2 of 6 pages of the initial draft. There were flow diagrams, bullet points, glossaries, not terribly family-friendly, to be honest. I was overwhelmed just reading it, and at that point, I'd already been working on PRRS for over a year. Thankfully, though, the team was incredibly receptive to my suggestions, and after some meaningful collaboration, the document was revised down to this abbreviated 2-page family-friendly summary sheet. In the spirit of family partnership and engagement, not only was this document reviewed and approved by our health literacy team at the hospital, but by a team of client and family members committed to relevant, clear, and easily understandable language. If I could give you a take-home from my perspective, it would be that PRRS is important for our children and for the families that support them, and that for PRRS to be successful, families need to be partnered fully in the process, solutions, and strategies. It's not easy, and it can be uncomfortable both for healthcare staff and family members, but without this meaningful partnership, this effort will surely not reach its desired potential. As a parent, I've come to appreciate that having a child with a chronic disability is frankly very difficult. The conditions themselves are hard enough, but the pains of navigating the system and waiting for necessary interventions are honestly just plain cruel. It's not okay, and it needs to change. As an engaged partner in the PRRS initiative, I know that my voice can help create system change, and that gives me hope that I have, and we all have, the opportunity to make this road a little less difficult for future families faced with this challenge. Thanks.
Adrienne, thank you so very, very much for your perspective. It really always grounds me and why I've been involved with this process. And it grounds me in terms of looking at where do we need to go. I'm going to just let you guys get a chance to switch over to CM driving the bus now. So where are we going with PRRS, and what do we need to make it look successful? Certainly going back to some of the lessons learned, both the ones that we learned through the initial data collection and onboarding of our phase 1 sites, as well as what we've just heard from Adrienne, there really is a need to think about the fact that if you think of the map that we showed you at the beginning of the presentation about the number of sites, there's a lot of work to be done in order to be able to bring more sites on board so that we truly have that comprehensive picture of services across the nation. What's it going to take? One of the key components is going to be leadership, and that's really leadership at all levels. We're really excited about the potential for so many of the BC sites coming on board. That's actually leadership happening both at those sites but also within the BC government. We need leadership at our administrative levels. We also need leadership at the levels of our clinical leadership to help with some of the change management. Organizational strategies are important in order to be able to implement this within your building. Partnering with families, we've heard from, certainly from Adrienne, how critical that is, because so many of the tools that we're using actually are family report tools, which again, because of the fact that families are often navigating multiple systems, we felt those were the most appropriate tools to be able to implement so that we could get that picture of what families were experiencing, but also that it be consistent in terms of, so even some of our intervention tools, families are the ones that are gathering the information about where they're getting their services from, whether they're using other types of services like alternative services. So we really rely on the family report, an accurate family report within this. So that partnership with families and some of the kinds of key components that Adrienne spoke to about thinking about when we're asking families to give us information that will inform us. We need certainly education, information, and resources to make this work. The other concept that this has really taken on has been that concept of this being a continuous improvement and a change management mindset. Even to move our clinicians from the old kind of impairment-based model to an ICF framework has taken sustained activity both at the clinical leadership level. We've done change webinars, and we've done different types of activities or things that parents and clinicians can have as takeaways. We also need to continue to look at the assessment and evaluation of what are the results. So our next phase really is starting to look at what reports are we going to get out, what's the framework for reporting, what kinds of meaningful indicators. We've got the indicators now. How do we combine those indicators to really give us some of those benchmarks that will help us move forward? But I think this is a bit of a plea and a call to action on all behalf of the pediatric rehab community. We really need the whole community to become PRRS members. If you look a little bit at the next slide in terms of impact on the village, Adrienne spoke about it takes a village. Here's where we see PRRS having the potential for impact, both at the micro, the meso, the macro, and the mega impact level. We've already taken PRRS internationally. We've presented at one of the quality international frameworks in Gothenburg, and there's sustained interest internationally in what we're doing in Canada. We're a leader in this in Canada, and we need to continue to be that. So if we think about those dreams that Adrienne talked about, the ability to have connected networks across Canada, PRRS is the tool, but it's really what also comes with PRRS that's so important, that networking across, the sharing stories of impact, improving access models of service delivery, leveraging data for resource allocation for clients and families, benchmarking our performance, learning from each other to improve the care experience, and then looking at those transitions and continuum of care, connecting the systems for pediatrics to adult care. They're things we strive for. PRRS is the tool that's going to help us get there in a more meaningful way. How do we look at growth and partnerships? We have certainly looked at that concept of the peer-to-peer implementation approach for new members so that there's support for new members coming on board. CIHI and CAPHC and CPDSN have provided tremendous technical support as we've worked through some of the issues, and we're now at the process of working together to provide our inaugural 2017 PRRS report that will be part of the CPDSN benchmarking, CAPHC benchmarking reports. So how can you find out more about becoming a partner in PRRS? Please contact CM Javid, and we will now open it up for questions from the audience.
All right, thank you, Dorothy, Adrian, and Siam. Fantastic presentation and really a great update on the work that's been it's going on for many years, and we're really starting to see some great progress. So just a reminder of the audience, this is your chance. Type in your questions into the question box. The first question that came in was early on when we were talking about the data elements, and Allison was asking, are you collecting any data on ethno-cultural identity and or socioeconomic status, and also how are you engaging with indigenous populations? So Dorothy, maybe we could start with you, and then maybe we'll hear Siam after that.
So we have done some analysis of what ethno data we're collecting. There was some issues initially related to what was possible at different provincial levels. And when I'm saying, because with some of the privacy impact we've done, and also looking at what is some practice within different provinces. So currently, we're not collecting, it's an optional program right now, or an optional data element. It's not a mandatory data element. Definitely the concept of collecting information on how many of our Indigenous population we're serving is something that is within the PRRS data set. But again, it's one of those mandatory, depending on which province you're in and whether that's something you're being collected, that is still really more at a local decision level. And as we work further forward, especially as we're looking at different populations coming on board and different diagnostic groupings coming on board, it may become more important. Socioeconomic, I know that there's some work that's being done related to that area as well, because we are looking at it in certain pockets of the province of Ontario. But again, when we're trying to look at a standardized collection methodology, sometimes these are the ones that we have indicated that are more optional data set elements as opposed to the mandatory. Sam, anything more you want to comment on?
I think that was great, Dorothy. I think you covered it, but I think I'll just comment on the process at each facility does vary, and out of respect for certain organizations, we couldn't make it a mandatory data element, although it came up a few times during the year of our assessment. So we've left it optional, and at the end of the first year of evaluation, I think it'll be an interesting data element to look at.
And Adrian, don't you hesitate either to jump in if you have anything else that you would like to add. Please just jump right in. The next question is just coming in, just asking where can people find more information? So, for example, copies of the 62 data elements or any other information about PRRS. Where's the best place to go, Sia?
Definitely, I think the slide is still up, so you can definitely contact me at sjavid@caphc.org. If you log into the CAPHC website, there is a page on the Pediatric Rehab Reporting System there, and so retrieving the information can be done that way as well.
All right. All right, once again, if you do have any other questions, we have about 5 minutes left, so we certainly would have some time to take a couple more questions. Adrian, maybe a question for you. Just wondering if you could give us a little bit of an example of how you really made the case that you felt life would have been better if you had access to data related to the services that your child was getting, et cetera. Can you give us an example of how you feel your life might have changed specifically? Is it just a matter of knowing, having information, knowing where you fit with respect to other children or other services that are being delivered, or is there something more specific and tangible that you can share with us?
Well, I mean, definitely, and thank you for asking. I think, to be honest, one of the first questions we talked about as a family is did we need to move? Because we knew just from speaking to other families that there were other provinces that had different levels of access to care, and that in our situation, because we were looking at early intervention, places that had decreased wait times in comparison to what we were looking at in Ontario for intensive behavioral intervention. So, I mean, really, it came down to the beginning of figuring out, were we in the right place? Did we need to go to a different place? Or if we couldn't go to a different place, what was it going to look like to get her the therapy that she needed in the interim privately, which is, which is something that some families have the option of doing and some families just simply don't have the option of doing. So that was kind of the first biggie. And then after that, it was really trying to understand the details of what it was going to look like for her day-to-day in terms of the planning of what interventions for how long, what the next one would be, and who would kind of guide us through the transition of point-to-point access into getting those therapies.
All right, thank you. Great. That's a great answer. Really, just for even that example of the wait times and understanding whether that impacts where you should live in order to get treatment. That's a great example. So, CM, maybe this is a question for you. Christina's asking about plans for onboarding specific organizations in year 3. So, what does that look like as far as engaging organizations that are already interested or just learning about PRRS? What's the year 3 and beyond sort of look like?
So I think it's important to note that onboarding is something continuous that we provide as folks join in or as they dial in to participate in the project. So it definitely doesn't end in year 2 or in year 3, and it's something that we're continuing to grow from month to month and year to year. So we do set a template or a platform for implementation, starting off with a conversation around the site lead who will be leading mostly the project at your facility and the team that will be participating in the data collection. So the requirement specifications document plays a key role in some of those early meetings, as well as an assessment of the nature of the electronic system at each health organization is another area, a key area that we start to explore in the early in the meetings as folks join in.
All right.
I'll step in for a minute as well. One of the things we've talked about is sort of a bit of that change readiness, having some type of a checklist for organizations as they're thinking about onboarding. What are the key elements that you need to consider, and then matching them with resources that we have available. I talked about some of the, clinical resources, but there are also other resources as well, just basic frameworks around change management, who needs to be on board, how do you engage your families in this process, some of those tools that we could then match to specific organizations that are interested in coming on.
All right, thank you, Dorothy. Dr. Gail Andrew, one of our close colleagues in our rehab work here at CAPHC, and certainly a big part of Cintra over the years, has a great comment saying, data not only tells us where we are at, but it's essential to tell us where we need to go, that the data is dynamic. So I think that's a great comment. Monette is asking if there is a fee or a cost to the organization to join PRRS. CM, any thoughts on that?
Yes, there is a participating fee to join the project. Is there a fee, any other associated fee? Again, that's a conversation that we start having depending on the nature of the organization and other resources that are either already existing in the organization or resources that we'll need to explore to support the facility. So it does range. But the pediatric rehab reporting system does have a yearly fee.
All right. So I think we do have time for one more question. If there is any last burning questions out there, we've got about 2 minutes left. And if there are any more questions, we will take one more. And if not, we will hand over to our panel just for some closing comments. Any sort of key messages or closing comments you'd like to leave the audience with. And looking like there are no more questions, unless someone's quickly typing, we'll start with CM and just anything you'd like to leave the audience with, and then we'll go to Adrian and then Dorothy after that.
I think maybe to leave the audience with this is that we're quite excited that about this unprecedented work, and really I wanted to recognize the dedication and the leadership within the pediatric rehab population, and how it has played a tremendous role in getting us to a very exciting stage to actually have our first inaugural report this year that we are thrilled to share with folks at the end of the year and in the future. And as we look into the PRRS system as a whole, to think about the future of capturing many other diagnoses, the future of it being captured as a national rehab reporting system is something that we're all very, very excited that we're getting movement and that we're actually going to have data this year to start making comparisons and reviewing. So I'll turn it over to Dorothy maybe.
Or actually, I'll save Dorothy for the end as the sort of the co-chair who's sort of leading this work. But we'll go to Adrian. Adrian, any thoughts from the family perspective that you'd like to leave the audience with?
Thank you. I think, when we think of data, often it's can seem overwhelming and confusing, but once we distill it down, and especially because we have our partnership with CIHI, and that we can start to understand trends and look forward, when it comes down to families, it means that things start to become more clear. We can have a better understanding of what's happening in our areas, in other areas, and then a better idea as to how to move things forward. And I think, the world of pediatric rehabilitation is complicated, and these conditions are complicated. So the more data we can gather to better understand things and help build a plan, the better the care is going to be for our kids going forward.
All right, thank you very much. And last but not least, Dorothy as co-chair, along with Sonia Pigura from Holland Bloorview, who's not able to join us, but sort of leading this work for the at least the foreseeable future. Anyway, anything you'd like to leave the audience with to close off?
I think, again, and it's a little bit of echoing on Gail's comments that she made earlier, the fact that as a sector, we have been hindered by our lack of data and our ability to advocate effectively on behalf of the clients and families that we're serving. So this is really going to be important for us as we think about competitiveness with other, and it's not that we're in a competition, but we recognize that the healthcare system has certainly had an advantage over us in the pediatric rehab world because they have more readily available data and they have more outcomes. It's been something that we have struggled for over a number of years, and often it's the, well, prove what you're doing makes a difference. This is going to enable us to prove that what we do makes a real tangible difference, and that's why it's so imperative we collect it and aggregate it.
All right, and I think that's a great place to end it off. Great presentation, certainly demonstrated the importance of this work and certainly highlighted a lot of the successes that this group has had in implementing this PRRS reporting system, along with the great partnerships that have been developed. So fantastic work, and congratulations to everyone, and thanks for joining us today. We do our webinars every Wednesday at 11 a.m. Eastern Time, and when you can watch live, it's really a great opportunity to ask questions and participate in the discussion. But as we mentioned at the top, we do record these sessions and post them on the Knowledge Exchange Network, so you are welcome to come back and watch any parts that you might have missed or share them with your colleagues, etc. Next week, February 8th, we will be having a presentation about safe transportation for children with orthopedic conditions. They'll be talking about current roadblocks. This will be a very interesting presentation for most of you who have attended today, as this will be about issues related to challenges that children and families face when their children are unable to comfortably or safely sit in a traditional car seat, whether it be because of physical disabilities or sort of post-surgical issues, things like spica casts and that sort of thing. The issue was brought to our attention by Dr. Richard Stanwyck from Vancouver Island Health Authority, who noticed that one of the car seats that was typically being used in this situation was being discontinued, the Hippo car seat. And that started a bit of an investigation into what devices might be available, what organizations and families could do to meet the regulatory requirements related to car seats in the absence of appropriate equipment, and what organizations like CAPHC or the Canadian Paediatric Society or organizations like that could do to advocate for better and safer systems for children and families. So along with Dr. Stanwyck from Victoria General Hospital, we'll be welcoming Natalie Bilodeau and Kathleen Montpetit from Shriners Hospital for Children in Montreal to share their experiences with the currently available devices and challenges associated with meeting the regulations within the province of Quebec, as well as them sharing some of the solutions that they've come up with. And then following that, on February 15th, we will be continuing on with the sort of advocacy theme to talk about how to succeed with your ideal for change, reflections on effective child health advocacy. And during this presentation, we will be welcoming Dr. Michael Dickinson and Dr. Andrew Link to discuss the latest edition of the Are We Doing Enough report that the Canadian Paediatric Society puts out. That's their biennial status report that evaluates public policies affecting children and youth in Canada. So our presenters will be highlighting changes to the document, reviewing the principles of effective child health advocacy, and applying these principles to 2 case studies. So some great presentations coming up in the next couple of weeks. Hopefully you will sign up for our email newsletters, and you will be able to join us then. So thanks for joining us today, and we hope to see you back here next week. Bye, everyone.